Case study number 7, adult medical. Date of patient contact was 4/24/17 and date of case studies today 4/29/17. Unit number Pava'a 1, the shift time 12 to midnight. Disposition for the case study is Queens ER and preceptor for the shift was Alex Berardo, MICT. Dispatch reference, abdominal pain. The scene presentation. Upon arrival, the patient is a 49-year-old female in the seated position in her car. The patient is alert and oriented ×3, speaking in full sentences and tracking well. The patient is clutching her abdomen and groaning with a facial grimace. Patient states she was on her way to work when the cramping started. The chief complaint is abdominal pain, and the patient is alert and oriented ×3 for the pre-hospital assessment. Alert and oriented ×3, speaking in full sentences, displaying no neurological deficits, and was eupnic, not hypotensive or tachycardic, and had strong radial and pedal pulses with normal skin signs. Since all that was true, we proceeded to help the patient on board the ambulance and transport her to the Queens ER. Physical exam revealed atraumatic findings in all body areas. The abdomen was soft in all quadrants, but painful upon palpation and release to the center of the abdomen. The patient states she was unsure if the pain felt like a GI type of pain or cramping or a uterine type of cramping. She stated it just feels like the worst cramping ever. The patient denies any capability of being pregnant. AVPU assessment, the patient is alert and responsive to verbal stimuli. OPQRST part of the assessment, the patient says the onset of the cramping was sudden. She denies any loss of consciousness, dizziness, paresthesia, or other neurological deficits leading up to the event. The patient states the pain feels better when she lies in a recumbent position, and the pain with her knees pulled up to her chest in some way. Q, the patient states the pain feels like the worst cramping she's ever had. The patient denies any radiating pain and states the pain is a 10 out of 10, and states the pain began suddenly with no significant events identifying the cause of onset. As the on-scene vital signs were conducted, including blood pressure, pulse, respiratory rate, 3-lead EKG, and blood glucose. Since the patient was not in shock, the vital signs, physical exam, and CMS were reassessed en route every 15 minutes, and the patient displayed no neurological deficits and was alert and oriented ×3 upon arrival at Queens ER. For medical history, the patient states she has no allergies to foods, medications, or other substances and is not currently taking any medications. The patient states she was sure she could not be pregnant and denies history of peritonitis, appendicitis, pancreatitis, cholecystitis, GI bleeds, bloody stool or urine, gastroenteritis, ulcers, bowel obstructions, hernias, and AAA. Does not have a history of smoking or excessive drinking. Patient states her last oral intake was breakfast this morning of a type of cracker that she hadn't eaten before with some juice and water, and states that she had a normal day and events prior were unremarkable. The treatment summary. On scene, the patient's on-scene treatment included initial assessment, the vital signs including blood glucose, physical exam, and assistance walking to the ambulance. In transport, the en route treatment included 3-lead EKG, vital signs, and physical assessment reassessed every 15 minutes. The admitting diagnosis or physician's impression: possible bowel obstruction, GI bleed, ulcer, or uterine complication, or something to do with abnormal food intake. ER floor treatment: the patient was treated in the ER floor by the ER floor staff and vital signs were taken. Blood tests were initiated and the patient was scheduled for radiological tests. In the patient follow-up of the patient revealed no peritonitis, appendicitis, pancreatitis, cholecystitis, GI bleeds, gastroenteritis, ulcers, bowel obstructions, hernias, or AAA. The patient had been released after finding that her cramping had been most likely due to abnormal food intake deviating from her baseline and possible minor malnutrition from eating less than normal and not drinking enough water. So in describing my feelings, observations, and reactions with regard to technical performance, interactions with patients, other EMS members, and personnel at the hospital. Since my initial assessment of the patient revealed her to be alert and oriented times 3 and that she was not in immediate respiratory or circulatory distress, I focused primarily on helping the patient to the ambulance, following the direction of the medic, and collecting accurate vital signs. This was the good opportunity for me to practice my vital signs skills, physical exam, including CMS checks, and to make sure that she was not hypovolemic or tachycardic or in any kind of situation where she was bleeding internally and could be in a state of hypovolemic shock. And also to check on to practice any lifting and moving skills in taking her into the hospital in the ER, as well as OPQRST and ample history. For a pathophysiological review, so acute abdomen is a syndrome in which occurs frequently in the pre-hospital field. An EMS provider should not be concerned with identifying the exact cause of a patient's illness, but rather focusing on whether or not there are immediate life threats presented through a thorough set of vital signs, physical exam, and an accurate history. If these tests reveal the patient to be hypotensive and or tachycardic, the measures for suspected hypovolemic shock should be taken. The patient should then be placed in a supine position and transported to the hospital immediately. If these tests do not reveal signs of hypovolemia, then the focus should be on comforting the patient and reassessing vital signs and physical assessment. Since there are several organs in the abdominal cavity, pain can be sourced from any one or combination of them. The organs include the stomach, 3 sections of the small intestine, 3 sections of the large intestine, the liver, gallbladder, spleen, pancreas, kidneys, and urinary bladder, as well as the visceral and parietal peritoneum. Since the majority of the organs of the abdomen are not vastly innervated, tearing or trauma to an organ will not cause significant pain. Rather, the pain that a patient feels from these types of trauma or illnesses that cause it are usually due to blood accumulating around the lining of the organ or swelling from the organ in the lining of the tissue lining the organ, which causes inflammation, which irritates the peritoneum. The peritoneum is the organ which most acutely senses and transmits pain signals to the brain in the abdominal cavity. The peritoneum is a highly innervated structure of tissue which helps suspend organs and keep them in place. Distension of an organ puts pressure on the peritoneum, which causes acute pain, and the peritoneum can itself become inflamed, which is a condition called peritonitis. So in this case, the gas from a deviation from the patient's baseline of food consumption may have produced an abnormal biochemical state in her GI tract, which led to gas, cramping of the visceral musculature responsible for peristalsis, and a distended section or sections of the bowels which irritated the innervated peritoneum. References for this case study are the pre-hospital medical textbook in chapter 23.